Today, we are joined by Dr. Ahmed from CDC, but before we go into that, I would like to welcome everybody that has joined us for today's session. We have people from Japaigo, HW21, we have Lewanika, Minga, Zaf Clinic, Monze Mission, Livingstone, Lundazi, Chilenje, I see Chimunya is sitting. We are joined by James and people from Chipata Central as well. Mazabuka, I hope you can hear us. We didn't do a sound check with them. Kaoma, and of course, we have Mateo level 1. We have Lina, and Petauke will be sharing a case. Here in studio at the hub, we have our colleagues from CDC. We have Dr. Mary Boyd, and what she said, we're her friends. I believe she may introduce them a bit later. We are joined by our expert panel. There's Dr. Rokaya, Dr. Thomas, and online we are joined by Dr. Loti Hachambwa. We are also joined by our HNPs from the nursing school. So we'll let Dr. Ahmed go into his presentation. As we are sharing, Dr. Mpeta, may you please give us a recap of the session we had 2 weeks ago, talking about what to do with patients who are failing their second line.
Thank you very much, and good afternoon, everyone. So this was on the 15th of April, which was a presentation by Dr. Sibile. Firstly, we talked about the definition of treatment failure, and that this was suboptimal response to therapy, and often it's associated with clinical, immunological, and virological failure. Clinical treatment failure was defined as any development of stage 3 or 4 WHO clinical staging condition in a patient who has been on effective therapy for 6 months or more. Then virological failure was defined as a viral load above 1,000 copies per ml in a patient who has been on treatment for more than 6 months. We also discussed about identifying the causes of treatment failure, which were broadly categorized into 2 as potence failure and adherence failure. And potence failure has to do with the drug selection. It could be that a weak regimen was chosen, or a wrong dosage was given, or there is prior resistance or drug-to-drug interaction. And then adherence also, and the different types of, or the different causes of adherence, poor adherence were also defined. Another important factor was malabsorption, which can actually lead to treatment failure. It was also further discussed that treatment failure is not the same as drugs not working, and neither is it equivalent to development of drug resistance. So adherence counseling was emphasized, and repeat viral load in assessing the patients who are failing. Patients who are found to have failed second line should actually follow the national guideline for referral to third line or advanced treatment centers. And we were also advised that we should continue the failing regimen as we await for the patient to be transferred or started on a new regimen. And
you through this topic. This is a very important topic to us, to I think all stakeholders working on HIV in Zambia. This is something that counts very much for us in terms of efforts to achieve the 95 in Zambia by 2020. It's a very important program area that goes to, that impacts the clinical cascade as a whole. So what we're going to do today, just provide you an overview of what we think is important in terms of viral load routine testing, concepts such as coverage, viral load coverage, viral load suppression, but more specifically some of the key roles and responsibilities that we think the person who is taking care of viral load routine testing activities implementation at site level needs to be taken as a whole. So to start, we can just have a look quickly at the 5 main objectives of this presentation. So we're going to try to explain what viral load routine testing, why viral load routine testing is important, discuss some definitions of some concepts that we hear about and that we use in terms of managing our viral load routine testing activities on a daily basis. We're going to explain the status of viral load testing in Zambia and what is the performance so far, what is the picture in terms of viral load coverage in Zambia as of 3 or 6 months ago. We're going to outline viral load champions' roles and responsibilities and discuss a couple of suggested ways of site-level monitoring for optimal implementation of routine viral load testing. So the idea is to generate at the end of this presentation an interesting discussion and have interesting questions and get sense of what are your perspectives at site level, what are your challenges and what solutions you've taken to address viral load routine testing and viral load coverage on your end.
So, first polling question. According to the 2018 Zambia Consolidated Guidelines for Prevention and Treatment of HIV, about the viral load, if it's more than 1,000 copies per mil, this always means that ART is not working. ART should be changed immediately if viral load is more than 1,000 copies per mil. Viral loads can help identify individuals in whom ART is failing. Pre-viral load results of more than 1,000 copies per mil are needed for a client to be switched to second-line ART. So we have some answers coming in. Only 3 of our facilities have answered. I must say, Sichili, you're welcome. We saw you coming. Kazungula, Sons of Thunder. And a special welcome to you, Dr. Chitembo. I know we met on the Easter Monday, and you're wondering why I wasn't in ECHO. We didn't have an ECHO session last week. So we have, that's how the voting is going so far. So some people feel that we need 3 viral loads results for you to change a patient, while others feel it can help identify individuals in whom ART is failing. Okay. So we'll move on. Okay, so that's how our results are looking.
So here you have a reminder of what the Zambian guidelines recommend in terms of frequency of viral load testing as a routine test. So the Zambian national guidelines recommend routine viral load testing at 6 months after ART initiation, and then at 12 months after ART initiation, and then every year, annually. So that's something that's recommended not only by Zambia, but also recommended by the WHO. So here you have an overview of why viral load routine testing is important. These are 3 key different reasons, and I think it's important to understand the rationale of why routine viral load testing is recommended in terms of raising awareness among staff that works directly or indirectly in implementing activities for viral load routine testing, but also with patients. It's very important to understand why viral load is important, viral load testing, and why viral load coverage is important. So from the individual level, we know that viral load routine testing proved to be more effective and more reliable as compared to CD4 testing in terms of achieving good outcomes, individual outcomes for patients who have started ARVs for at least 6 months. That means patients who are assessed for viral load on a routine basis have shown, based on evidence and even in program data, that they have lower rates of loss of follow-up and lower mortality. And viral load monitoring can also promote motivation to stay in care and adhere to treatment. So these are some of the individual benefits, and you can refer to the very last slide of this presentation, where we have some references, where you can see the details about the evidence that WHO and other countries based their decision to recommend routine viral load testing as opposed to CD4 testing as a means to assess success of treatment and adherence of patients who start ARVs. From the population level and public health benefits, this is something very important. It's related to reducing new infections, and that's one objective, that's one goal of our program, is to reduce new infections, not only providing treatments and keeping patients who are on ARVs on treatment, but also making sure that we decrease the rates of new infections or incidents. And we know that viral load routine testing contributes to that greatly, because when you have a high viral load coverage, you make sure that you know those who are virally suppressed as compared to those who are not virally suppressed, and it makes it easier for you to assess the effectiveness of your program. So in terms of transmission, the evidence, we have a number of key studies that have been conducted in the past 10 years, starting from 2009, going to 2012 and 2016. Mainly, we remember the study that was the basis for WHO to decide on recommending the test and starts, not waiting for CD4 to decrease. That study showed that after a 5-year follow-up from 2012 to 2015 or 2016, it showed also that virally suppressed patients were not transmitting the virus to their partners. Other studies were added to that one, and they were a basis in terms of proving reduction in incidence related to viral load suppression. We have partner 2, and opposite attracts. And these studies included discordant couples among heterosexual discordant couples, and also males to males couples. The results, the findings of these studies found that the transmission was 0 when viral load was suppressed. And that was consistent across the 4 studies. So that's a very strong and robust evidence that showed that as long as you have a suppressed viral load and you make sure that your patients have a suppressed viral load, you're making sure that you're contributing to a reduction in transmission of HIV. In terms of programs, in terms of the benefits on the program, you know that we are emphasizing the implementation of differentiated service delivery models that are aimed at making it easier for patients to receive HIV-related services. But one prerequisite to enroll patients, stable patients in those models, is having a result of a viral load. So as long as you have a viral load result, you're able to enroll patients into DSD models, and you're then able to make sure that you're decongesting your facility and making sure that the quality of HIV services is improving at your sites. This is what you've seen recently. This is the undetectable equals untransmittable, and this is just a more illustration of what I've said earlier in terms of the evidence that when patients have suppressed viral load, the risk of transmitting the virus is 0. And this is a table that illustrates that concept based on the category. Here we're going to address some of the most common definitions, concepts that we deal with every day. We have viral load coverage, viral load suppression, high viral load, and viral load cascade.
So we have our second polling question, which says, according to the 2018 Zambia Consolidated Guidelines, for prevention and treatment of HIV, all clients on ART should have a viral load done at every visit. CD4 count is an accurate predictor of virological failure. Clients on ART for more than 6 months should have at least one viral load done every year. All clients initiating ART should have a viral load done at baseline. So we have a few facilities answering. I know we're joined by Mazabuka as well. Okay. So I'm sure you can see how that's going. We have 30 more seconds for the poll. Okay. So some people feel that all clients on ART should have a viral load done at every visit. While about 96% of our people think that clients on ART for more than 6 months should have at least one viral load done every year. Okay, so we have 1 second to allow people to vote. People in the hub, please feel free to also have a look. We've distributed the poll around. So we have, oh wow, 31 people have voted. That's a big number. 32. Okay, so some people, we only really have people thinking it's A or C. Some people feel that all clients on ART should have a viral load done at every visit. Clients on ART for more than 6 months should have at least one viral load done every year. So at this point, we'll share the results and move on with the presentation. Okay.
Okay, so this is the first definition that we all know, and this is just a reminder. So it's basically the viral load suppression. Viral load suppression is made up of numerator and denominator. The numerator is the number of ART patients with suppressed viral load, meaning less than 1,000 copies documented in the medical laboratory records. And the denominator is the number of ART patients with a viral load results documented, and that's very important, documented in the medical or laboratory records. So it's a proportion out of those who had at least one viral load in past 12 months, how many of them had less than 1,000 copies as a result. So that's the definition of viral load suppression.
And are you saying we should only consider patients on ART for at least 6 months?
For at least 6 months, yes.
So we don't do it at baseline?
Yeah, the national Zambian guidelines recommend doing the first viral load test at 6 months after ART initiation. So this is the viral load coverage. It's the numerator is the total number of clients who have at least one viral load results documented in the 12 months prior to the end of the current reporting period. And the denominator is the total number of clients who have been on ART for 6 months and longer as of the end of the current reporting period. That means this is the total of number of clients who were known to be active on ARVs 6 months prior to the end of the current reporting period. So that means just to, we can further explain through this slide. So if you are to calculate your viral load coverage as of today, for example, so you're gonna have to have a look at how many clients, how many patients on ARVs had at least one viral load result documented in the 12 months prior to today's dates. That's the numerator. And the denominator is the total number of patients who have been on ARVs for at least 6 months. That means that those who started ARVs 6 months prior to the dates of today must be excluded from the denominator because they are not eligible for viral load routine testing. That means that the total number of patients on ARVs that you will take into account and use as a denominator is the one that you had as of the end of the reporting period that ended 6 months prior to today. So that's basically the viral load coverage. You can use the total number of patients on ARVs as of today without excluding those who have been on ARVs in the past 6 months, but that's going to be a proxy viral load coverage. It's still valid, but if you want to be exact, this is the exact definition.
Thank you very much.
Another concept that we would like those who work on HIV and those who are directly or indirectly involved in implementing activities for viral load routine testing, especially at the site level, is the viral load cascade. This is a very effective means to assess the progress in terms of your viral load implementation, activities implementation, and it allows you to identify the gaps and the challenges at different steps of your process of doing viral load routine testing, from establishing the number of those who are eligible up to getting the results and acting upon the results you get. So as you can see on the slide, you will see that if you collect complete data, accurate data on a regular basis, and not only at the provincial level or at the IP level, but also at the site level on a regular basis, at least every couple of weeks or every month, you'll be able to identify what are the problems that are preventing you from having an optimal viral load routine testing program. You can see the gap, for example, between the second bar, which represents the total number of those who are eligible for viral load routine testing, meaning those who have been on ARVs for at least 6 months, and the third bar going from the right-hand side, the viral load results documented. And you can see how many thousands of patients have not received the results, or they didn't even have a viral load test done. And that's something that affects as a whole the program, because that's a number of patients who you don't know the outcome. You don't know if they are adherents, you don't know if they have suppressed viral load, and they are contributing to HIV transmission also. Yeah, next. So the other concept also that we are emphasizing when we go to the sites and when we have meetings with our partners and we interact with those who work at the site level is the high viral load cascade. So similarly to the viral load cascade, that's a graph that, if done properly, accurately at the site level, can allow you to see how effective you are in terms of dealing with those who have a suppressed viral load at the site level.
On the third objective? Yeah,
the third objective will just touch on a very brief overview of what viral load routine testing status in Zambia is at this point.
So third polling question, ensuring the viral load is done on the client's records in a timely manner is the responsibility of the viral load champion alone. We have an overwhelming force, but it's only one person. So you need 30 more people to vote. Do we think this is the role of the viral load champion alone, making sure that people get their viral loads back on their files in time? It should either be in their electronic health records or in their paper file. Is this only the job of the viral load champion? No, so there you go. So everybody seems to think it's not true. Okay, then we'll just close the poll and share the results and move on. Okay. So your third objective.
So this is a graph that represents the clinical cascade, the 390s in Zambia as of the end of 2018. And as you can see, Zambia as a country showed about 69–70% viral load suppression rates among all people living with HIV as of the end of December 2018. That's a gap of 370 or 375,000 people living with HIV who either they didn't have a viral load test done, or they have a viral load that's not suppressed. That's between 300 and 400,000 people with non-suppressed viral load. So here is a list of few of some of the issues that we find at the site level when we conduct site visits. When we interact with viral load champions or focal persons, we realize that they are not very much aware of the full scope of their roles and responsibilities. Not all sites have a routine system to follow up on viral load testing. Not all sites know the definition and how to calculate routinely the viral load coverage that we just saw a few slides ago. Not all sites also are able to generate daily viral load lists of those who are due for viral load testing, combined with appointments for the same weeks, for example. And viral load registers are not always up to date, and especially high viral load register. There is also, it's not everywhere, but most of the sites we visit show a backlog in terms of results return and entry in the system. So this is basically a brief summary of what we find at the site level. Now we're going to go through what the roles and responsibilities of the viral load champion at the facility level, at the provincial level, and at the district level. This is just to show how many program areas and how many areas involve viral load routine testing. You can see that there is transport, there is data management, there is analysis of data, there is data entry, and there is specimen collection. So this is just to show that viral load routine testing is something that involves different program areas. At the facility level, the champion, so at the end of this presentation, you have the full list of roles and responsibilities at each level, but these are just few of those roles and responsibilities. At the facility level, the viral load champion is supposed to know the viral load tests targets at the facility level. He's supposed to track daily progress of the viral load testing, compile the results, compile weekly viral load progress, ensure that the facility has all required viral load data entry and coordinates with the data entry staff to print the daily lists for patients who are due for viral load testing. And also the champion, the viral load champion, is supposed to flag also the files of those who are eligible for viral load. Another set of roles and responsibilities include coordination with the facility lab team, keeping records, filing the results, making sure that the high viral load results are being entered and recorded in the high viral load register and acted upon. And also the viral load champion is supposed to ensure that all clients with complete enhanced adherence counseling have a repeat viral load and fast tracks these results to the clinician for appropriate action. So so the facility level, now looking at the district level, it's similar, but it's just a different level. The viral load champion at the district level is supposed also to know annual district viral load targets and receive weekly progress reports, coordinate with the provincial level, the provincial viral load champion and the implementing partners, and also tracks and monitors viral load coverage, turnaround time, and viral load suppression rates. The roles and responsibilities for the viral load champion at the provincial level are similar to that of the district level. So now we're going to look at the suggested ways of site-level monitoring for optimal implementation of routine viral load testing. What we suggest is that immediately, this is an immediate step that's a prerequisite for any viral load routine testing program you have at the site level, is that each facility should have a viral load targets, annual, monthly, weekly, including pregnant women and breastfeeding women. And this should be shared with the district and the provincial medical officer. And these are the outcomes that we suggest could be used to monitor at the site level. At the beginning of every week, for example, we can get a list of those who are due for appointments and viral load testing in that week. And at the end of the week, come up with the proportion of those who actually got their viral load result done and the list of those who did not. The other outcome we can look at is out of those who had a viral load test done more than 2 weeks prior to any given reporting period. For example, if you're looking at today, 2 weeks ago, how many patients had their viral load test done. You look at how many of them have their results back and documented in the system that's being used at the site level. The third outcome we can look at is out of all those known as having had an unsuppressed viral load results, how many did not have a second viral load yet within at least 3 months following the first viral load testing. So to summarize, we recommend that each facility has a viral load targets, and also, so that's the main recommendation. At least that's a good start at the facility level. When you have a target, you know the progress you're making throughout the time. This is just to show that viral load routine testing activities involve different program areas, including clinical, lab, and M&E. And this is the list of references used to look at the evidence we looked at for the transmission and the benefits from the individual level and the population level at the beginning of the presentation.
Thank you so much, Ahmed. At this point,
thank you very much.
We'll allow any questions from our network. I know I followed up one of the references you put up. One of the papers was by Ben Chi, who I believe used to work for CIDES. And the study that you referenced there looked at Zambia, Malawi, and South Africa. I think they have a place called Kailiche or in KZN. So this was at a time when Zambia was doing CD4 counts. We're not doing viral loads because we're saying as a resource-limited country, we can't afford these viral loads. And they showed some interesting results in that South Africa, which was doing viral loads, they had less loss to follow up, less mortality, and less failure. And what was very interesting and very key, what we are seeing in the loops is if you delay your enhanced adherence counseling and do it even 6 or 9 months later, your chances of resuppressing the patient was actually much reduced than if you do it within the first 3 months. That's why it's very important to have that viral load on time and acted on. If you get it 9 months later, it doesn't help. So there's a question from Yeta. How do you calculate the viral load coverage? Okay. Are there any other questions before Ahmed goes on to explain that mathematics? And I'm happy.
You can go back to maybe to the slide. No?
Yes, I can go back.
Okay. Well, I mean,
okay. Are there any other questions before we go to the calculation? I know Dr. Ahmed was at pains to explain that because unfortunately, if this data is reported wrongly, it tends to skew the data for your province or your district. And remember, if you do a viral load at initiation, you may show that a lot of your clients are actually failing. But these are patients who are actually not even on ART. So it's important that you pick those that have been on ART for at least 6 months. If you do it too early, you will show that a lot of your clients are unsuppressed. So there's a question from Yeta asking about this.
Yeah, so going back to the definition of viral load coverage, so you look at it from this perspective. You have a number of patients. You have, for example, 1,000 patients who are on ARVs, active on ARVs in your cohort, you're following up on in your sites. Out of those, how many are eligible for viral load testing? So to come up with that number, you rely on the definition that's in the Zambia national guidelines. Who is eligible for viral load testing based on the national guidelines? It's anyone who have been on ARVs for at least 6 months. So whoever have been on ARVs for at least 6 months in your cohorts will be eligible for viral load routine testing. And what you would want to assess in your cohorts is out of those eligible, how many have effectively had at least 1 viral load in the past 12 months, because that's the definition of routine viral load testing. And if you come up with the number of those who had at least 1 viral load test documented out of those who are active on ARVs in your cohorts, that defines your viral load coverage at your sites. So if you have, for example, 800 out of the 1,000 patients who are active on ARVs in your sites, 800 had at least 1 viral load in the past 12 months, meaning the 12 months prior to the date where you're assessing your viral load coverage, that means you have 80% coverage of viral load routine testing at your site level.
Thank you so much, Ahmed. Petauke, please go ahead with your contribution or your question. Petauke, please go ahead. Thank you so much, Ahmed, for going through that. Would you like to, as we get Petauke ready, because of time, just to talk about the 4 questions? Petauke, please go ahead.
We wanted to ask about the viral load and DSD. The recommendations are that we should create put clients on DSD models when they have at least 2 viral loads suppressed. Now, majority of our clients, they have 1 viral load. It's maybe suppressed. So what do we do? Should we wait for the second viral load for us to start DSD? Or what is the orientation who can help us? How can you help us?
Thank you. I think Dr. Okaya would like to answer that question. Thank you so much, because as we give Dr. Okaya that, I feel like you touched a bit on the 4 questions. So not every patient needs to have you don't know viral loads at baseline. We only do it at 6 months. And for you to switch, you need 2 viral loads. Would you like to touch on that so that I don't have to report?
Sure.
Because I know we said 3 viral loads, and I know some people said 3. Is it 3 or 2?
No, it's 2 viral load tests, 3 months apart. So when you're doing routine viral load testing, you're going to come across unsuppressed viral load, meaning viral load results with more than 1,000 copies. In that case, what you have to do is to repeat the viral load 3 months later, not 6 months, not 9 months, not 1 month, but 3 months later. That's the ideal situation. That's what needs to happen. Because if you have a second viral load that's unsuppressed, you will have to switch promptly. And what happens during those three months, you will have to provide enhanced adherence counseling sessions to that person, to that patient who has a unsuppressed viral load. And what we've seen and what the evidence showed, as Dr. Sombo mentioned earlier, is that you will be able to make sure that you resuppress at least 50% who have the first viral load that's unsuppressed. So if you have, for example, 500 unsuppressed viral load, if you manage to provide 3 enhanced adherence counseling sessions within 3 months and you repeat the viral load, most of the time you will have at least 250 who will become again suppressed.
Okay. So the most crucial thing during that period is that between the 2 viral loads, there should be some enhanced adherence counseling, isn't it? Yes. So you have a very short window to actually suppress your patient, and enhanced adherence counseling should happen. I know there's a comment from Patrick who says there is need to enforce the role of the viral load champion at facility level. I think they are saying good presentation, Dr. Ahmed, but they are asking about the TXML and TX retention. What would be the best way of tracking the TXML?
Okay.
Yeah.
So that's a topic of a whole new presentation.
There's a whole
and I would love to be involved in that, because that's also something that's key to our program in terms of retention, in terms of monitoring retention. So we would be very happy to provide answers later, maybe if you want. But that's a very important.
Thank you, Molly, for inviting Ahmed back for TXML. Actually, that's an echo session, so it looks like we found a presenter. So, Dr. Okaya, are you able to advise us? Our patients usually have 1 VL, and our current guideline for DSD is that people should at least have 2 suppressed viral load. Essentially, they should be on ART for a year, is what that means. Would you like to speak to that?
Yeah, for patients who have started treatment recently, you expect that you do a viral load at 6 months. Then when they clock 1 year, you repeat a second viral load, and it's suppressed, then you'd consider them well suppressed and ready for DSD, as long as the other criteria are also met, meaning that they don't have any other problems. But we know that we started viral load testing recently. For most of us, this is the first year, probably the second year. And we have patients who have been on treatment for 10 years, 12 years, and you do the first viral load and they are suppressed. And we see that a lot in the clinics. So the assumption then is that the adherence is good. You again have to make sure that these patients are not pregnant, they don't have mental health issues, they don't have any other non-communicable diseases, all the other criteria for DSD. If they qualify, then you can still go ahead and give them a 6-month appointment.
So that's for people who've been on ART
for much longer.
For much longer than a, which makes perfect sense. That's a very good question, actually, Bill. So, Bill, are you ready to present your case on viral load? As I mentioned, we have been joined by Dr. Hachambwa, who's joining us remotely. We have Dr. Mpeta. We have, of course, Dr. Rokaya. So, Bill, are you able to see our slide set? So, Dr. Bill? Peter, okay. Oh, he's muted, actually. Just unmute him, because you can start with another case. Okay. Yeah. Hi, Bill. Please. Hi. Okay. Are you able to see our slide set?
Not yet.
Oh, not yet. But please go ahead and start presenting, because I know you have the slide set. We have a yellow on our screen, which means that people can't see our slides. Yeah, please.
Yes, the case will be presented by Mr. Zimba, our ART in charge for Petauke District Hospital.
Okay. So, yeah, welcome, Mr. Yotam. Please go ahead with the case.
Okay, thank you so much. Like it has been said by Dr. Kavala, I am Zimba Yotam presenting the case for Petauke District Hospital. Next slide. Okay, so we have a female old client, female 40 years old, and this client is a widow. She was diagnosed HIV positive in 2010. So she started ART 4 years after she was tested HIV positive. That was in 2014. And the first line regime that she was put on was TLE. Now, this is a client who lives just 2 kilometers from the facility. And this client lost 2 of her 5 children due to unknown causes. This client was as well screened for TB, and she was tested TB negative in January 2019 after screening for TB. Now, this client had 2 clinical appointments that she missed. That was in 2016, and she had enough drugs after a follow-up was made, and she actually had traveled out and she was assisted with the drugs. That's why she still had the drugs even when she had missed the appointment. This is a client who does not take alcohol. Next slide. Thank you.
Are you able to see that? Okay, perfect.
Yeah, so on physical examination, when she was put on ART in 2014, she had weight of 49 kgs. In 2016, her weight was 64 kgs. She went up, and in 2018, the weight went down to 54 kgs. So in 2019, her weight was 54 kgs. Her BP was 100/53 millimeters of mercury, and her pulse was 88 beats per minute. Respiration is 20 cycles per minute, and the temperature of 36 degrees Celsius. Her height is 150 centimeters, and their BMI is 22. And this client appears well with no abnormalities detected on physical examination. Talking about medication summary, in 2014, when we put her on ART, the regime was TLE, and it was commenced on 27th of July 2014. And this regime was stopped after the lab investigations, as we'll be seeing later, on the 17th of December 2018. Now, in 2018, she was put on AZT3TC and atazanavir boosted with ritonavir. That was on the 17th of December 2018, and up to now, she's still taking the same regime. Next slide. Thank you. So let us look at the lab results now. This client, she had the first viral load done on the 27th of November, 2017. So that was the time that specimen for viral load was collected. And from 2017, we managed to receive the results on the 14th of May, 2018. And that translates to 6 months after we collected the specimen for viral load that we were able to receive the viral load results. And when we received the viral load results, the readings were 35,563 copies per mil of viral load. So since then, we actually engaged the client into EAC, and we repeated the viral load on the 18th of July 2018. So the results, the specimen that was collected on the 18th of July 2018, again, we received the results on the 17th of December 2018, and that translates to 5 months down the line after we collected the second viral load. And the readings were 45,008 copies per mil. So when we received the second viral load results, we engaged or enrolled the client into EAC, and we collected the specimen again. So by 17th December 2018, when we received the second viral load results, and seeing that the viral load results were again above 45, above 1,000, we switched the client to second line. And this switch was made after receiving the second viral load results on 17th December 2018. And the regime was AZT3TC Atatanava boosted with ritonava. That was the second line regime that we had put it. We had put the patient on. Now, on 26th of February 2019, this client was due for CD4 count. Coincidentally, this client also was collected the viral load. And now, the results for the viral load came 202,000 copies per mil. And the white blood count was 3.6, HB 13.5, hematocrit 41%, and platelet 338. AST was 30.8, ALT was 28.3, and urea was 2.4. So this client still maintains on the same second-line based regimen, AZT3TC, ATV, stroke, ritonava, and septrin. Now our question is, this client was switched to second line, and still 9 weeks later, still increasing in terms of viral load. How do we manage this client? That's the end of the case presentation. Thank you.
Thank you so much for that presentation. It was pretty clear. But just to take people back, we have a 40-year-old lady, HIV diagnosis in 2010. In 2014, she was put on TLE. About 3 years down the line, they managed to get a viral load, which was 35,000. Unfortunately, the time between the collection of the viral load and the viral load getting to the clinician was a good 6 months. So it was actually not acted on. By the time they were getting to the clinician, another viral load was collected while on TLE. And that viral load also took a good 5 months to get back to the load. I will not comment about the timing of the viral load, but paradoxically, there seems to be a significant rise in the viral load as opposed to a drop, or at best, maybe maintaining within the same log. We'll take some questions from the network for Bill and Yotam. Thank you so much, Yotam.
Thank you.
Are there any questions for the team in Petauke? Do we have questions? Or even from our experts, do we have questions? The screens are full. Do we have any questions for Yotam? So Dr. Tambwa has a question.
Yes, just a few questions. Thanks for the very good case presentation.
Thank you.
Was any viral load done at the time of switch in December 2018? The second question is, what was the turnaround time for the viral load that was done in February? We seem to be improving. Initially, it was 6 months, 5 months, and now maybe 1 month. Third question, what were during enhanced counseling, enhanced adherence counseling, what were the reasons for treatment failure? What were some of the barriers to viral suppression that were identified at that time, and how were they addressed?
Thank you so much, Dr. Achamba. Some very interesting observation there. But I'd like Bill and Yotam to answer those questions.
Okay, thank you so much. The first question was there a viral load done in December before the switch? The answer is yes. The viral load results that came in December was actually the specimen for viral load that was collected in July, and was just a delay in receiving the results. So I would say yes, the one that we received in December was the second viral load, which was also above 1,000. If anything, it even went more than the first viral load results that we received. Then what is the turnaround time now? Really, there's a drastic improvement from 6 months, it went to 5 months. But now I think the turnaround time is within 3 weeks we're able to receive the results. And I think it has even gone further now with the e-labs, at least within a week we're able to receive the results. So there's a drastic improvement in terms of turnaround time for the viral load results. So talking about, was EAC done? Yes. When we received the first viral load results, though it was collected in December and results were received in May, when we received the first viral load results, we were still able to do EAC, and thereafter, that's when we actually collected the second viral load, which again delayed to come, and received the results in December 28th. And after receiving the results that we saw, it was again above 1,000. That's how we managed to switch the client to second line based regime. Thank you.
Maybe to add on, we haven't identified any reason that would explain the failure on this client. We screened for opportunistic infection, there were nothing, and we assessed the adherence, there were nothing.
Okay, that answers the question. We had a question typed out for you saying, is this client adherent to a medication?
Yes, yes, she is
adherent.
Oh, wow.
Yes. Amazing. Thank you, Bill. There's another question. Do you know the status of her partner? I know we said she's a widow.
Okay, we are sorry, that area, we haven't checked it so much. We need to go back and check that area. Okay, the new partner that we have, yeah, we haven't checked that.
Oh, are you saying she has a new partner?
We don't know if she has a new partner. The only thing we know is she's
looking at the age where she is.
Okay, life begins at 40. So, Matero, please go ahead with your question.
Thank you, Dr. Sombo. Our question, I think they have answered it a little bit. We had the deep enhanced adherence counseling, but we wanted also to hear on risky sexual behavior, because reinfection with a resistant strain of virus in this case. So if they can elaborate more on that, it will be helpful. Thank you.
Thank you so much, Dr. Chibango. I guess everyone is thinking it's paradoxical, right? At the very least, the PI should be working for some time. But I don't know if Dr. Mpeta or I'm not seeing any more hands. Could this be a case of reinfection? We need to try index testing. It seems, Dr. Bill, one of the recommendations is you track down her sexual partners so that you see why she's having this paradoxical type. And there's a question, did you consider what HIV type the patient may have? Like, did we think it may be HIV 1 or HIV 2?
Yeah, the client is having HIV type 1.
Okay, so it's HIV type 1, isn't it? Interesting, because at least on the second line, she should be fine. But it's HIV type 1. I don't know, Dr. Mpeta, if you want to ask a question or comment on that Before I go back to Dr. Achamba, because I have an inkling that...
I think it's clear in terms of what we need to know about this patient. It's quite interesting that despite well adherence, although there's only one gray area that we haven't explored, and this is the possibility of reinfection with new partners. I would also want to think that the other area which was not well explored is the late husband. Did he have HIV? Probably he did. What line of treatment was he on? Was it first or second? Was it the case of primary drug resistance? And then since the woman is still under drug pressure, then we expect that the primary resistance should still persist. It will be interesting to know if the husband died while being resistant to second line, which could be the case probably in this patient, or he was highly treatment experienced with multiple, mutations, which can actually explain the wife, the surviving spouse, to have such kind of, resistance pattern or failing. That is, if we rule out the fact that she's not in a new relationship with new risks. That's, I think, one of the things I can think of.
Thank you so much. Everyone keeps on going back to she may have gotten a resistant virus. But Ahmed, would you like to comment on that turnaround time that you are getting with these viral loads? How helpful is a viral load that comes 6 months later?
Yeah, so this is a very good example of a mismanagement in terms of viral load routine testing and what needs to be done when we find a high viral load. That's why we said earlier in the presentation, I think ideally what we should be doing is repeating a viral load within 3 months. We maximize the chances that person will have suppressed viral load after a repeat. Following effective enhanced adherence counseling sessions. So that's just to emphasize the importance of having complete data, accurate data, using the high viral load cascade, having high viral load registers up to date, and using them for quality services to improve also viral load routine testing and to act on the high viral load results we receive. This is a very good example of what should not be done, and I hope this is understood by everyone at all sites who are following us.
Okay, thank you so much. And thank you so much, Poitauke, for this case. I feel like it really brings what we experience in the clinical setting, isn't it? We get all these late viral loads. Some people have even 6 viral loads done of them with no result. So, and at the end of the day, as we mentioned, once you lose that 3 months, your chance of resuppression is reduced. Dr. Rokaya.
Okay. I just want to comment on basics first. I know we talked about the partner having a resistant virus and maybe if she has another partner reinfection, but I think going back to this patient, I would still want to explore adherence first, because most patients will swear that they're taking drugs, but you really need to spend a lot more time and effort to find out what the issues are. She was taking a once a day regimen, and now you've moved her to AZT3TC with the PI, so that's a BD regimen. So if she failed on the first line once a day regimen, I'm sure she had more issues trying to take twice a day, and I would want to go back to the basics and explore the adherence first.
And sorry, just before, maybe before you move, I remember that there was a point which was said this woman had more drugs and hence did not come for clinical appointments. How do you have more drugs? Was it a case where since she was taking 2 types, she finishes 1 bottle and then starts another bottle? Because it's a bit odd that you would be given more drugs than your appointment.
Especially if you look at the time when it happened, it was 2016. We're not giving people 6 months. By then, it wasn't in our policy, and like now, where you can give for 6 months. So I think Dr. Mpeketa gets the feeling that she was skipping some of it. So she had lots of this stuff home because she's taking it once a week. So I think one of the recommendations that's very clear is that we need to go back and check what her adherence is, because that paradoxical rise in viral load it's very paradoxical. It suggests very poor adherence. But Dr. Achambwa would...
Too short. 2 months is too short.
So Dr. Rokai is commenting on when the viral load was done. We said 2 months. 2 months is
2 months
short.
later on.
Yeah.
Too short.
So there's another recommendation here. I don't know what the team or the network thinks of it. Matero is saying we need to do another viral load now to compare with the previous one. I don't know if Dr. Achambwa, you would like to comment on this.
Oh, hi. So maybe I'll just kind of comment on some of the things that Dr. Mupeta and Dr. Ginwala mentioned. So I think the first thing, at least what I would do is go through the list that Dr. Mupeta mentioned at the beginning of the session, reviewing Dr. Sivile's presentation. I would have either a small piece of paper in front of me or have it in my head, all the possible reasons why people failed treatment. And when I asked the question of what were the reasons that were found during EAC for treatment failure, if the reason turns out to be 0, then the EAC was not really that effective. Because you should find a reason. If you find no reason, you switch to second line and the patient will fail. You switch to third line and the patient will fail. So I think having that mental list of all the possible reasons patients fail, and then going through the checking that list and see which one you identify in that particular individual and then address it. If you find 0, it means that you've not really managed. You haven't gotten through. You need to try again. Now, what Dr. Mpeta mentioned, the patient missed 2 visits in 2016 and said she had enough medicines. It's unlikely that she went somewhere and they gave her enough medicine for 6 months, even though she wasn't best at that clinic. So there's a bit of incomplete information there. I don't think she had drugs for the whole six months or 2 visits that she missed treatment. So that's one area that suggests that she's not taking her drugs. Then the other things is what made her go away from home for that long period? What kind of work does she do? Does she travel a lot to a point where she forgets her medicine? People go for a funeral for 2 or 3 days. They come back, they will come back for the appointment. But if she was gone for 2 visits, that means that maybe her work might be affecting. And then she lives away from home. From the distance from the clinic is 2 kilometers. I don't know if that's significant, but those are some of the things to consider. Concerning repeat viral load, yes, I would repeat it now to compare with the one from February, and then go through that issue of EAC and find the real reason for failure.
Thank you so much, Dr. Achambwa. But I think another thing that he mentioned previously is if I were you, Bill, I would go back and get very clearly when this viral load was gotten. My gut tells me this viral load was done before she switched. Somewhere in December, somebody looked in the system and saw 200 and whatever that number is and switched her to your second line. She probably has not had a viral load done on her second line, unless she's so poorly adherent as people have suggested. As for a viral load, I guess the time for a viral load is actually now. It's also a bit surprising that she got a viral load so soon into her second line. It may be the loop that we are not getting right. Maybe that 202 is before actually the switch. And I'll just go through the recommendations because it seems unanimous. I don't see a hand. Our recommendations to you, Dr. Bill and Yotam, aside of course saying thank you so much, because I'll tell you the case you've presented is not unique. And sometimes us as facilities, we want to do the best for the patient. We've collected our viral loads, but somewhere in the continuum, the one that Dr. Ahmed demonstrated, transport, entering of results, somewhere there's a break, and that viral load we got arrives 6 months later and it's difficult to act on. So thank you so much for bringing this case. It's very useful, but it also tells us it's important to check the dates, when it was done, when it comes back to you, and I'm very happy that you showed us that. So the first thing is we need to check her adherence. We'll send you the checklists. Is she traveling? Does she have other partners? How come Because sometimes, like in your case, you have evidence that in 2016, she had a lot of drugs when she should have had a little. So maybe you can probe in that direction. Also, it's been suggested to check her partners. Does she have other partners? Can we do some tracing and index testing on these? You can go ahead and do a repeat viral load to see actually what's happening to her viral load. But I think the most important thing, as emphasized by Dr. Mpeta, Dr. Ahmed, and Dr. Hachambwa, is this is it's a red flag that she may fail her second line truly, and she will need enhanced adherence counseling. So I think for now, the best thing you can do in terms of management is reinforce her adherence. What is going on? She needs to really, really be checked for that before you can even make any further tests in terms of genotype. We need to enforce her adherence because the possibility is that she may fail another line and will run out of drugs. I don't know if those recommendations are clear.
Yes, very clear.
Very clear. Okay, Dr. Achambwa has an addition. Please go ahead, Dr. Achambwa.
Okay, just like the viral load coverage is confusing, the last slide that Dr. Ahmed shared on the I think he called it either the next steps or suggestions. I'll probably suggest that it goes through again a little more slowly like he did for the viral load coverage so that everyone is clear on that last slide, the one before the references.
Do you have also the list of the organograms for the
or the organogram?
Yeah.
Oh, I see it was out.
Anyway, yeah.
You can just check. You can. Mine is not coming up. So you're supposed to go through that. You can start.
No, not go through. Just lets them know that it exists.
The organogram.
It's comprehensive.
No, okay.
I will go to all the roles.
Which one does Dr. Achambwa want you to go through?
The outcomes.
Oh, this one.
The
last one. Okay. Sorry, Dr. Achambwa. So you say that he goes through the one before your references.
Oh, sorry, before that, sorry.
Before this
one, the outcomes?
Yeah, I think, yeah, this slide, yeah.
Yeah.
You kind of emphasize things that can help.
Yeah, so I mean, this is my, my perspective on what can be done at the site level in terms of weekly monitoring of how the viral load testing is going. It just to get an idea, a brief idea, and start acting on what's happening. You can look at weekly numbers of those who are due for viral load testing, and those including with appointments. For example, next week on Monday, you generate lists of those who are due for their clinical visit, but also for their viral load testing. You have that list and you make sure that everybody is aware of that so that you can make sure that they are tested. And then at the end of the week, you look at the proportion of those who actually got their results, their viral load testing done out of those who are on that list in the beginning of the week. And so you can get a sense of who didn't get a viral load, who didn't come to their visits, who didn't get the tests done, and you start acting on that. So that's the first thing. You can do that every week. And you can also have a cumulative list of those who didn't have their viral load tests. And you update that list as you try to trace those patients who didn't come for their viral load testing. The second one is about getting a sense of how long it takes for viral load results to come back to the site. So the time frame there of 2 weeks is just because the standard now is that because we have enough capacity at the labs, we have enough PCR machines to comply, to help with the demand and all the viral load samples that are sent. So there is no, the likelihood of having a backlog now, unless there is a very major problem, it's very low So it's very unlikely that you have a backlog. So you should have your results back to your sites within 2 weeks. That's the standard we set at our level, and that's what needs to happen at all levels, even at the site level. So if you look at those who had their viral load 2 weeks and more, you look at how many of them had their viral load results back and have also their viral load results documented in the system. So that gives you an idea about the turnaround time, going from sending the samples up to returning the results and documenting them into the system. And the last one is about following up actively on those who have an unsuppressed viral load. So the idea is to always have an updated list, a cumulative list of all those who have an unsuppressed viral load results, who we didn't manage to follow up on so far. So you always have to have that list, and so it gives you an idea about how many of those with unsuppressed viral load had a repeat viral load within 3 months. And that's possible only if you have an updated, if you have a high viral load register that's up to date. That's what a high viral load register is for at the site level. It allows you, if it's properly completed, it allows you at any time to get sense of how many patients you have at your sites who had an unsuppressed viral load and who didn't have yet a viral load repeat test within 3 months.
Okay. Thank you so much. But there's another slide of yours that caught my attention, and on the demand creation. How do we do that? Because I know as of Tuesday next week, we are going into the U is equal to U campaign. Would you like to?
Yeah, so that's something I'd like to share with the audience. Is it's the U equal U campaign that's supposed to be taking place at all sites. So the idea is to emphasize the importance of having a suppressed viral load, not only among providers, but also among patients. So there is a process of coming up with materials and resources. This week there will be a meeting. It's called a scientific meeting to look into the evidence and ways of summarizing that evidence and translating them into flyers or resources, that can be used at the site level to raise the awareness in terms of viral load testing and the importance of viral load suppression. The same way you would, several years ago we would emphasize CD4 testing with patients and providers. Now it's viral load testing and especially viral load suppression. So that's what it's about.
Thank you so much, Dr. Ahmed. With that, we wrap up to today's session. I must mention, thank you so much, Dr. Achambwa, Dr. Mpeta, Dr. Okaya, Dr. Patel, Mary Boyd and team. And thank you so much, Bill, for your case. Next week is the 6th of May. We may have a session on TB meningitis. That is the session that is planned, but our mentors will be in a meeting, so we may cancel this, but I will communicate after confirming. Thank you very much, and see you. We'll communicate.